bit now just how you've gotten to this point with the program or the model you're developing.
Yeah, what I want to do is I want to draw a model on the board behind you, Jake, because this is what I use with patients all the time, patients and families, and this is our center point, is the patient is here. I mean, you can put the caregiver there too. And then with that, you know, kind of think of this as we're trying to stay in the middle. I'm not an artist, okay? So that's about as good as it's gonna get. And then our domains of well-being, we know they're more complex than this, but generally is physical, functional, social, and then emotional. But I'm going to put spiritual in here too, because it can be faith-based, I tell patients, or it can be just existential that we were talking about, your roles, kind of who you are. So I'm going to leave this here because I think as we talk through living well, you know, I was supposed to go first, but I had things I had to go take care of in my own family. So actually it's interesting that the dying well went first, because actually to live well, you got to plan to die well. Does that make sense? And I think we don't do that enough in our lives. So this is a focus that I spend with patients. And with this, then we do a quality of life assessment. And it actually asks specific questions in each of these domains, because quality of life is subjective, completely subjective, just like pain. You know, the health professionals ask you, what's your pain on a scale from 1 to 10? And you're like, well, you know, a 3. And we think, a 3, well, this is a person with a high pain tolerance, so a 3 to them is like a 10 to me. Do you see where I mean, it's all perspective, and I think for us in healthcare, we need to sit down and get to the essence of how do you validate these domains, okay? So a great example of living well is I had a guy that had stage 4 lung cancer, and he came in and he was in his 80s, and he had bone metastasis had spread to his bones, and he was in really bad pain. So of course, as health professionals, we're focusing on the pain. You know, pain, you gotta help, you gotta help, you gotta help, you gotta do these things. It's absolutely totally right, but there was something deeper that was going on with him. And when he met with me, we did the domains, and his actual physical and functional well-being were high. Perspective. His emotional and social and spiritual well-being were low. Why? Not just because of his diagnosis and his prognosis was not good. He was the caregiver of his wife who had dementia. They don't have family. They're living in a home. He was terrified for her, not for himself. Make sense? So when we stopped for a minute and readjust, like he's saying, where is the distress? What is your biggest concern? How do we look at it and allow to say, can I offer additional support that's either in your community, within our practice, within yourself, within just being told, this is real? You know, we were talking about chemo brain not too long ago. You know, the whole reality of having somebody validate how you're feeling is real, okay? So really kind of starting at a certain point of saying, do we know how to live well? Number one, healthy, okay? But then now we've got this being that's with you. And one lady said, I feel like it's this being that's like alongside of me and I don't know how to control it. I said, I get it. You know, you got to get one of those leashes. And saying, okay, let's pick it out. Because when you have so much coming at you, you don't know what is really hitting me. Is it my physical and functional that's impacting me? Now, in this guy's situation, I said yes as a health professional, but in his case scenario, it wasn't. His bigger distress was him being the caregiver of his wife. And when I said, you know what, I'm going to connect you to our social worker, we're going to find some resources in the community, I'm going to get home care out to start doing some assessments and kind of start looking at this stuff, he cried. And he said, I know my life is short here, but my whole life has been her. And I am scared for her. So managing the fear, okay? Managing those things that, what is distressing you, where is it at? If it's physical and functional and something I can help control as a health professional, sometimes that's my job. But the job of the survivor or the patient or the caregiver is to let us know, with help, what's getting you. Because that helps you live well. See how the balance is? Kind of all that balance. And what I tell patients is, if your biggest distress is physical and functional, well, what's happening to the ball of you in the middle? It's getting pulled to physical and functional, right? Boom, 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 boom. What happens to your social and your emotional well-being? It gets lost. So how do we balance it? Okay, with the thought of what we know in our lives prior to cancer is not saying that's forever lost, it's changed. So managing the grief and loss of what was, kind of the would've, could've, should've type things, to where I am now, we have to modify with it. That's the emotional part. That's the psychology. That's the hard part, as Jean Marie was saying, as us as beings, that we don't like, we don't necessarily like change. Now I'm one of those freaks where I love change. I mean, I love change. Change it up, shake it up. Otherwise life is boring. Let's move, let's pull, let's push, let's see if we can work smarter, harder type thing. But I know people look at me like I'm crazy. So it's kind of just finding where you are yourself. Now, I also take this model and look at my caregivers. Say, you got your own model. You got your own circle. You got your own domains. You have your own things. So how are you managing that, the self-care piece, to then look at what am I struggling with to really address that in the caregiver component? Because if they do, then they're not clashing. Do you know that's not hitting head to head? The caregiver can say, I do need a break. I need an afternoon for 2 hours just to go. And the patient's got to say, you know what, that's okay. You got to refill. And thank you so much, or whatever. That kind of giving back and forth, because we all have these domains. We all have these pieces that are complex, and they pull and they cross each other, and how do we live well, but really looking at those domains and quality of life. So whenever I speak to nurses across the country, I challenge them. I write the diagram. A patient was the one that got me to get to this, because she said, I have so many things going at me, I don't even know what I should be worried about, Michele. So I was like, okay, well, let's draw this out. I came up with this with a patient. Makes sense, doesn't it? It's like, okay, now, what physical things? I'm nauseated. I'm worried about losing my hair. I can't get up to make my own lunches, because I can't stoop down where my stuff is, okay? I write them all down. Now, what can we do to change those things? And then how is that impacting your emotional, spiritual piece? And then how does, because of your emotional, spiritual, because you're physical and functional, guess what you're probably doing? Socially isolating. Not on purpose. Not a lot of times are on purpose. It's just that I'm tired and I can't do this. Okay, so how do we manage fatigue? See how it goes all for a circle, and trying to help people figure out how to live better. So I think that I felt bad that the dying well went first, but actually the dying well is actually a good thing to go first, because what we all have in common is we were born and we're all going to die. That's everybody in this room. That's something we guaranteed have in common. Okay, that's a journey. And we don't know when that's going to happen. We don't know how it's going to happen. And really it's about how do we preserve as much as we can these domains of well-being. Okay? Does that help?
Very much so.